All right, friends, our next segment of the ATSNJ in 60 podcast, we're going to really focus on current concepts of shoulder instability. And I'm excited to have Dr. Chris Spagnuola on to talk about a few of his key take-home points that he presented. Chris is a board-certified orthopedic surgeon specializing in sports medicine, and he works with Seaview Orthopaedic and Medical Associates. So, Chris, thanks for taking a couple minutes to chat about some key takeaways. And I want to get right into some of these key points. The first thing is you talked about, what athletic trainers should be looking for when they're assessing for a possible acute or recurrent dislocation. So what are some diagnostic approaches athletic trainers should be taking when they're looking for that?
Sure. Well, thanks for having me today. Of course, a couple things. When you approach a player, these injuries happen so fast. Sometimes you can't tell that the force was violent enough to dislocate the shoulder. It usually happens when the arm is abducted and externally rotated. So someone landing on an outstretched arm, a player trying to be tackled, and their shoulder pops out. So one thing, when it's a complete dislocated shoulder, they will be very much in pain and apprehensive. They'll be guarded. One of the postures that athletes will take with a dislocated limb involving the shoulder is the arm will be adducted at the side with internal rotation, and they'll hold it close to their body and be afraid to move it. Their exam is going to show limited range of motion, and they're going to be very guarded. So if you have a thin athlete and and they're out of their pads and their shirt's off, you might see some dimpling of the skin from the distraction of the shoulder. It usually is in an anterior and inferior position. These are some things to look for in your clinical exam.
And you mentioned that if there's a posterior dislocation, they can commonly be missed. Why is that?
Posterior dislocations sometimes are not as painful. They will have a little bit of range of motion. And when you take an x-ray on the x-ray, depending what view you get, it may not look dislocated. So from the emergency rooms, because for about every 20 anterior shoulder dislocations, we might see one posterior. They're commonly missed.
That's something that we have to be aware of, because if you're going to miss it, and especially if you don't suspect it, you just suspect it's a sprain or a basic sprain or strain, and you send them back into play, then you're setting them up for more significant problems. So ATs need to be aware of that. What happens? Okay, let's say you do identify a definite dislocation. What considerations should the athletic trainer be taking pertaining to, should I attempt to relocate this? Should I not? And then you talked about the various approaches to relocating as well. What would your advice be for athletic trainers?
Assess the situation, assess the player. Do a quick neurovascular exam, make sure they're able to wiggle their fingers, extend their thumb, cross their fingers, and make a fist so they're neurologically intact in the upper extremity. Take a pulse. And if they're good, when you guys assess them quickly, the muscle spasm hasn't settled in yet. So a lot of times they can be reduced with very little trauma. So if you have a mechanism that you're pretty clear cut with a shoulder dislocation, the exam's consistent with a shoulder dislocation, any gentle maneuvers okay to try. Some of the things I've mentioned in my exam, a good way to do it is if you can get them to your training room and put them prone on a table, you can tie weights to their wrist, like a pail with a bucket of water, some weights that you have, and just leave them gently distracted for 10 or 15 minutes. And sometimes that will do it on its own if you catch them quickly. Other times you can just, after they've been distracted for about 10 minutes, you can put a hand on the scapula and just push the scapula immediately and pull the arm towards the floor, and it can gently snap back in pretty much atraumatically. And giving it, maneuver like that, it's okay to try once. If it doesn't go, don't try multiple times, then you can ship them out to the emergency room. But if you can get them quickly, you save them a trip to the ER, you save them conscious sedation, and can take them out of a lot of pain. Plus, the longer they're out, sometimes it can cause more instability as well. So getting reduced quickly is really important.
When you were talking about the scapular approach to relocation, like I don't know if I've just missed that, but I thought that was genius, because then you're focusing on opening up the space and just trying to let the arm do its own thing, let the humerus do its own thing. But if you clear the scapula, rotate it out of the way, I thought that was a great approach that could really help for people that are really guarded. So
Yeah,
that was
it's
awesome.
really guarded. It's very atraumatic. And like you said, it just opens up the space so the shoulder falls back and you're not really doing much traction. The traction, counter traction technique, when you throw a sheet around the person to pull the arm, that's a little more forced and a little more violent. The other approach, laying prone, is a little easier.
Absolutely. And the last thing I'll just mention for the athletic trainers is make sure you have a great relationship with your team doc, your overseeing athletic training medical director, because you should be having these conversations with your doctor about what are you comfortable with? Is there something in your plan of care if your state practice act allows it? What are you allowed to do so that you and the doc are on the same page? Whether it's, you got to get on the phone with the doc right before you do it or whatnot. So that's a really important conversation the athletic trainer and the physician should have that you most closely work with. The last thing, Doc, is I want to talk about those key rehab and return to sport considerations that you believe in when you're handing that athlete back off to the athletic trainer or they're returning to rehab. What are you looking for after dislocation?
So, you're getting through those 3 phases of rehab. Initially, you want to let the inflammation calm down, slowly regain motion. Once you've got your motion and pain under control, you're going to add in strengthening. And once you have good strength and full range of motion, you want to add some dynamic activities like plyometrics and sport-related activities. And when the athlete's got near full range of motion within 90% of their full range, near full strength, and no pain with athletic activities, they're okay to resume practice. In this type of injury, I will let students and athletes resume their current season. And if they do need a surgical procedure, it can be done at the end of the season.
That's good to know. And that's always, especially if you're dealing with a high profile athlete, what is their future? That's always a intricate decision to make in terms of, do you go into surgery? Do you put it off? So it's good to know that, as a physician, you support looking at all aspects of that. And, we have to really make a big picture decision when it comes to that athlete, what's best for long-term as well as short-term. If it's a collegiate or professional athlete versus a high school or middle school kid, big difference.
Sure. I think it's very important. I think one of the other things to look at is if you have a football player who's wrestling and he dislocates his shoulder, I'll tell him, why don't you stop wrestling? Let's fix and get ready for football season. Or if it's a football player looking for a college scholarship, it's a senior year. We want to get him back in play so we can get as many games as possible so we can get seen by the scouts. So you have a lot of flexibility, and it's very important to see what the athlete's really looking for out of his sport.
I appreciate that perspective. Dr. Spagnuola, that was a great talk. Thank you for your key takeaways. Appreciate your contributions to sports medicine in our state, and thank you for your time.
Thanks for having me. I appreciate it.
You're welcome.